We are going to move on to hear about the Alfred and how it's responding to family violence. So we have Bridget Wall and Cathie Smith, and they're going to explain how their social work and emergency department teams are working together to initiate the Alfred's response. So welcome to you both.
Thank you. I'd like to start by acknowledging the traditional owners of the land on which we meet today. My name's Bridget Wall and I'm the Manager of Acute Social Work Services at the Alfred, and I'm joined today by Cathie Smith, who's our Allied Health in the Emergency Department team leader. Our presentation today is entitled Initial Responses. We gave it this title because we wanted to share with you some of the initial steps we've taken at Alfred Health to provide a response and support to the predominantly women who present experiencing family violence. As most of you already know, the Alfred is a large statewide service of adult trauma, burns, HIV, cystic fibrosis, and a number of other specialty statewide services. Oh, there we go. For a number of years, the social work service at the Alfred has undertaken professional development in a range of areas, including family violence. This education has taken many forms for us, from guest speakers, from specialised family violence agencies, through to case presentations. In 2011, due to an increase in social work demand, we developed a priority tool. Priority 1 referrals for social work is anything that we consider a response and assessment must be completed within 4 hours of referral, or in other words, the most urgent referrals. Family violence, sexual assault and elder abuse are all Priority 1 referrals for us. So what that means is that if a dedicated unit social worker is not available, this referral is then allocated across the department for urgent action. This is where education and training in family violence is crucial for all my staff, not just those working in trauma and emergency department. It is also crucial for all the social work staff working both after hours and on the weekends who will encounter family violence presentations. In 2015, the Social Work Service approached Australian of the Year Rosie Batty to work with us on developing an organisational-wide guideline and to tell us her story and recommendations for a large public health service such as ours. What started out as a very small professional development session for just social work turned into one of the largest attended forums in Alfred Health history. In terms of raising awareness of this issue, we certainly met that target. There were many aspects of Rosie's presentation that stood out for us. Rosie spoke to us firsthand about her experience of being in hospital and of the various staff she met during her stay. She stressed that if women are in hospital, for whatever reason, whether it be childbirth or as a result of a trauma, they will be reluctant to open up to staff if they are unfriendly and rude. Acknowledging that we all have busy days, Rosie stressed the importance of staff knowing how to engage and communicate with their patients and clients. She also spoke to us about the importance of staff having the confidence to ask questions if something doesn't quite feel right, and to trust their intuition, and to ask questions about whether the woman feels safe, particularly around discharge planning. And this is where staff support and education is vital. Rosie stressed that family violence is more than just patient care, but our workplace community as well, in terms of the hospital being responsible for its staff as well as our consumers. So we were keen to capitalise on this momentum. I seconded one of my senior social workers to work on developing a hospital-wide guideline and policy. Rosie spoke so passionately about the need for all hospital staff to be aware, not necessarily know how to intervene, as we've already heard this morning, but to be aware of what they can do in terms of support and referrals. So starting with a guideline to assist staff in the practical aspects of what to do was an important first step for us. This policy and guideline has now been approved by Hospital Executive, and we are now at the point of needing to educate staff about its content and how it can work for them. Antenatal screening occurs at Sandringham Hospital, which is operationally managed by the Women's but is part of Alfred Health Service. Alfred Health is also about to establish an executive-sponsored working group to oversee the education and reporting within the hospital. As we've already heard, the Royal Commission listed 4 conditions that support health professionals such as us in hospitals to identify and respond to family violence beyond just the treatment of injuries. These are institutional and executive support, effective screening protocols, initial and ongoing training, and immediate access to on-site and off-site services. All four are crucial to provide supportive and timely response. The work that we've commenced at the Alfred has had strong executive support, a vital factor to ensure organisational-wide take-up. As we also heard, the Royal Commission made numerous recommendations, some specifically focusing on the role of public hospitals to report that women access services at various stages in their lives that are high-risk periods of family violence. A woman might not be ready to disclose on the day of her arrival, but she needs to know that the hospital is a safe place to access 24 hours a day, 7 days a week. The Commission also heard that the likely under-identification of family violence in hospitals as well. A vital recommendation was the need for all public hospitals to accurately capture and collect all presentations via its Victorian Emergency Minimum Data Set. The Social Work Service has taken it a step further and will also be capturing more detailed data around family violence presentations. The Alfred has been operating a health legal partnership for 2 years, and we have lawyers on site who are able to provide information, advice and referral without the client needing to access an external legal appointment. And follow-up appointments are then provided during subsequent medical outpatient appointments.
Hello. I'd like you all to think of a time you've been involved in a traumatic incident where you may have been injured or experienced a trauma. Where did you want to be? I imagine it was somewhere safe, with people you knew and trusted. However, many people find themselves alone in a busy, chaotic ED with bright lights, overcrowding, little privacy, having to complete assessments and disclose highly personal information, often repeatedly, around other loud and distressed people. At times, this assessment may lead to the need for a mandatory child protection report, which impacts directly on your trust of the worker and potentially will deter you from presenting in the future. And what if English wasn't your first language? All of this, by its very nature, throws up some big challenges for clinical work. Given this context, it's often a challenge to engage in a meaningful way and is made worse due to the pressure of need for timely charges, constantly needing to keep the department aware of patient plans, waiting on responses from services in the community, and that's often whilst also seeing numerous other patients. A challenge when working in an acute trauma hospital for adults is that staff often do not look beyond the immediate injury and consider how it may have happened or whether there may have been children present. This curiosity to consider family violence needs to be a 24-hour department-wide response, which requires us to increase and support learning in what is a high turnover staff environment. An example of this recently was that a woman presented due to family violence, and when I looked back in her history, there'd been a number of past presentations of fingers being jammed in car doors, rib injuries, that all indicated what was probably a longer history, but none of them had been documented as family violence incidents. From an organisational point of view, when staff are completing the fields for the ED data collection, the presentation is collected against an injury type rather than the code that reflects family violence. So our stats don't really reflect the number of people who are presenting, which has been mentioned before. Once identified as family violence, the challenge is to work with the person to arrange supports and services and develop a safety plan that's supportive of the person, not seems what a list of overwhelming tasks. Certainly when we're able to access support workers who can come to the ED and help the person with the practical tasks on discharge, it appears to me that this is a better option than sending someone off post-trauma into the community alone. Not all people will have these issues, but many of our clients may need to immediately get to court, change locks, pick up medications, make arrangements for children or pets, liaise with mental health services, Office of Housing, Department of Human Services, Immigration or Police. And this is all in the context of having just experienced a trauma, a potentially painful injury, and probably very little sleep. In my lifetime as a social worker, I have seen a shift in service response and a greater awareness that people will have numerous interrelated issues, particularly in the areas of drug and alcohol and mental health. There has been a shift, which is good, but we have a long way to go.